will be given by me. My name is Dr. Sharif. I'm from New York State University, where I'm doing my training, and my interests are in rheumatology. I'm going to present a case report on a rare autoimmune disease. I will share my screen with everyone now. Can everyone see? Can everyone see? Okay. All right. So I'll begin. This is a case of fever of unknown origin and mesenteric mass. It's called a case of Kikuchi-Fujimoto disease and systemic lupus erythematosus. So a little introduction about KFD. It is a rare autoimmune disorder. It manifests with prolonged fevers and lymphadenitis. KFD is most prevalent in Asian females, and it's usually proposed to be triggered by infectious agents in genetically susceptible patients. So diagnosis is mostly by exclusion and then is confirmed by lymph node biopsy. In most patients, the symptoms resolve spontaneously, but sometimes we have to use glucocorticoids for remission. This is a case of KFD, which is unique in terms of its age of presentation, the ethnicity of the patient, as well as the clinical manifestations. So going into the case, this is a 24-year-old African-American male who came in with 2 weeks of epigastric pain and fever. On admission, his vitals showed a temperature of 101 degrees Fahrenheit, and on exam, he had epigastric tenderness. We did a complete blood count and comprehensive metabolic panel, which was unremarkable. The CT abdomen was performed, and it is shown here. There was a heterogeneous soft tissue mass in the mid-abdominal region, as shown by the green arrow, and there were also some mild infiltration of mesenteric fat, as shown by the blue arrow here. This is the coronal image of the same scan, and it again shows the heterogeneous mass in the abdomen and some additional prominent lymph nodes which were visualized. We did a CT-guided core biopsy of the mesenteric mass and lymph nodes. And it demonstrated the necrotic lymphadenopathy. I have shared the slide here. The patient, once we saw that he was impaired, we presumed it's ceftriaxone and metronidazole for 6 days. He did respond to that. His symptoms resolved, and he was discharged home. Here, the slide that showed associates with leukocytes and lymphocytes. However, the patient returned again after a week, and this time he had nausea, vomiting, weight loss. Again, he was febrile to 101.3, and he had a heart rate of 114. At this time, we were thinking of the differential in terms of autoimmune diseases, infections, or malignancy. So on the readmission, his white count was 1.84, and he had an absolute neutrophil count of 0.8. So he was neutropenic. Hemoglobin was 12.1, ferritin 598, LDH and haptoglobin are also given here. The rest of these are the remarkable results. The rest of the infectious workup that we did, including the cultures, blood cultures, fungal cultures, the viral panels, hepatitis panel, HIV, EBV, it was all negative. So we also sent an autoimmune panel, including ANA, ribonucleoprotein, and smooth muscle antibodies. We did a urine protein creatinine ratio to see if his kidneys had gotten a hit and wanted to evaluate his renal function. So again, thinking in terms of these three major differentials that we had, for malignancy, we performed an open biopsy of the mesenteric lymph node. That he was Given the fact that he was neutropenic, we also started him on IV and vancomycin and piperacillin tazobactam, but his clinical status remained unchanged, and so we administered filgrastim. We were also considering the possibility of lymphoma and leukemia with the lymphadenitis in his abdomen. So we did a so we did a bone marrow biopsy, and it was negative for myeloid, for atypical cells, basically. So myeloid to erythroid cell ratio was approximately 3:1, and they were maturing myeloid cells. Megakaryocytes were also shown with hypolobulated forms, and there were a few plasma cells as well. So here I've shared a histopathological slide of the mesenteric lymph node open biopsy, which we initially performed thinking in terms of some kind of malignancy. It showed multiple lymph nodes having large areas of necrosis with apoptotic debris. But the small lymphocytes around the necrosis were CD3 positive. Reactive germinal centers in the periphery showed B cells. There were no granulomas, or viral inclusions. We did a flow cytometry, and it did not show any neoplastic cells. So looking into the ASH guidelines, the American Society of Hematology, the presence of karyohexes and proliferative plasmacytoid dendritic cells is pathognomonic for KFD. Here I've shared this slide, which shows a center of abscess with karyohectic debris admixed with histiocytes, small lymphocytes, and plasmacytoid monocytes. There's no granuloma and neutrophils identified on this slide. So here I've shared the diagnostic criteria for systemic lupus erythematosus. It is called the SLIC criteria, where a patient has to meet at least 4 criteria, including 1 clinical and 1 immunological or lab criteria. Proven lupus nephritis with a positive ANA or anti-double strand or anti-DNA antibodies. So going over the clinical criteria, the patient may have acute or chronic cutaneous lupus, oral or nasal ulcers, non-scarring alopecia, arthritis, serositis, hemolytic anemia, thrombocytopenia, or leukopenia, and a renal or neurological dysfunction. Going over the immunological or lab criteria, a patient should have ANA antibodies, anti-double-stranded antibodies, anti-smooth muscle antibody, anti-phospholipid antibody, low complement levels, and a positive direct Coombs test. Our patient fulfilled the SLIC criteria based on the following four criteria, including the positive anti-Smith antibody. The titers are 1 to 40. He was leukopenic, as mentioned before. He also had lymphopenia. And as I mentioned before, we had ordered a urine protein creatinine ratio, which was raised on 2 levels, on 2 separate occasions. So it was 0.5 initially, and then we repeated it a few days later, it was 1.2. So given that he fulfilled 4 out of the given criteria, he met the SLIC criteria of diagnosis of systemic lupus erythematosus. And this diagnosis in setting of the of the histopathological slides, our patient was diagnosed with Kikuchi-Fujimoto disease along with SLE. So we started the treatment with steroids, sodium withdrawal 40 milligram IV every 12 hours. And in the following days, his fevers resolved, his clinical status improved, and 6 days later, he was discharged from the hospital on a tapering regimen of prednisone. Since we had seen that his kidneys had also gotten a hit given his elevated urine protein creatinine ratio, we started him on lisinopril as well. So after 2 weeks, we followed up with another urine protein creatinine ratio, and it was decreased to 0.2. We did attempt to do a kidney biopsy because we were concerned for development of lupus nephritis, but the biopsy was not able to include any glomeruli, so it was non-yielding. Over time, as outpatient, we added hydroxychloroquine and we tapered the patient off of steroids completely, and he continued to improve clinically. So there are several interesting aspects to this case. So this case is unique, even for a rare disorder like KFD, because it is atypical in terms of gender and age of presentation when compared to a similar population. So initially, the KFD was considered one of the etiologies of pyrexia of unknown origin and was first described in Japan. So it was seen more commonly in Japanese and Caucasian populations. There is a lack of large-scale or international studies on KFD, so epidemiology is still not very clear. However, there are smaller studies on African Americans, which does show a mean age of onset of almost 30.5 years, and a female preponderance. So compared to this data, our patient was atypical because he was younger and he was a male. But on top of that, his presentation was even more unique. So KFD presents mostly with fever and lymphadenitis. And amongst the lymphadenitis, the cervical lymphadenopathy is the most common. The involvement of mesenteric nodes, mediastinal, iliac, and retroperitoneal nodes is very rare. There are other symptoms that patients present with are very vague, including some skin lesions, arthralgias, myalgias, weight loss, night sweats, fatigue, headaches, which are similar to many other infectious or inflammatory etiologies. So our case is unique because this patient presented with mesenteric lymphadenitis and fever as the initial complaint of this disorder. Mesenteric lymphadenitis being the initial complaint was seen only in 5 cases since 1999, and I have listed those cases here. And you can see that most of those patients were Japanese or Caucasian. Moreover, the diagnosis was always made by excisional or laparoscopic biopsy, and the improvement was seen after surgical excision of the involved area or of the lymph node. So this patient is probably the 6th case and is doing well on oral medications. Going into a little bit of genetic predisposition of the disease, we have seen that there's a higher frequency of haplotype HLA-DPA1 and HLA-DPB1 in patients with KFD, and it indicates a genetic predisposition to the disease. So KFD has a strong association with SLE and infections. It is proposed that viral infections in these genetically predisposed individuals tend to trigger an inflammatory reaction, which can in turn lead to stimulation of autoimmunity. But the exact pathophysiology and the mechanisms involved in infectious triggers, autoimmunity, and development of KFD is still unclear. However, the evidence is strong enough that whenever we have a patient with KFD, it warrants a complete infectious and autoimmune workup, especially to look for concomitant SLE. Our patient did, like I said, our patient fulfilled the SLIC criteria, and it makes it the first reported instance of mesenteric KFD, leading to a new diagnosis of SLE. So KFT is a diagnosis of exclusion, and it is confirmed by lymph node biopsy, like our case. But many patients undergo various imaging studies before we can come to that diagnosis. They undergo ultrasound, CT scans, PET scans, and invasive procedures, imaging-guided FNA, core biopsy, or even excision biopsy. Even our patient went through multiple biopsies before he was diagnosed. And given his rare presentation of a rare disorder, he was a victim of a lot of excessive investigative techniques, and this leads to the need for standardized diagnostic criteria for rarer disorders like KFT as well. I would like to go into detail of types of KFT, which is also indicative of its progression with time. The first type is proliferative Kikuchi-Fujimoto disease. This type is based on histopathological picture of the lymph nodes involved. So in the proliferative type, the lymph nodes show paracortical expansion. It is caused by increased proliferation of histiocytes and dendritic cells, and it creates a dense meshwork to entrap the karyohectic nuclear debris. This then moves on to formation of focus of coagulative necrosis in the lymph nodes, which was also seen in our patient's biopsy. And then this further develops into xanthomatous phase, where some histiocytes convert into foam cells. And this is the phase, or this is the type, which has been reported as distinct non-resolving variant of KFT. So our patient had necrotizing type, and it was also noteworthy that majority of lymphocytes are CD8 positive compared to CD4 positive T and B cells in our patient. So KFT often resolves in 6 months, and the treatment is only for symptomatic relief, like antipyretics and NSAIDs. But glucocorticoid treatments have shown some good response, especially in cases with concomitant lupus as well. Most patients are given high-dose glucocorticoids with a slow taper and continuous monitoring of symptoms. Less common treatments include hydroxychloroquine with low-dose steroids, immunoglobulins, ciprofloxacin, minocycline. So there is no standard guideline on the treatment, just like there's no standardized diagnostic criteria for KFT itself. Steroid dosing and the combination of different treatment therapies in these patients, likely because of its rarity and lack of data so far. Our patient responded well to glucocorticoid therapy, followed by hydroxychloroquine drug. But again, this case reflects that, like